So for those of you joining, welcome. We're going to get started as close to 3 o'clock as we can to be respectful of your time. Everybody will be on mute, and I'll make some housekeeping announcements in a few minutes. So thank you. So again, welcome. This is Kathy Keogh, Executive Director of the National Association of State-Controlled Substances Authorities. We're going to get started in a few minutes, go through a few housekeeping issues, and we're just going to wait for a few more people to join us. Thank you. So we're going to just give it a few more minutes, if people would bear with us as people are logging on, and then we'll get started. Thank you. All right, why don't we go ahead and get started? This is Kathy Keogh, Executive Director of the National Association of State-Controlled Substances Authorities. We just have a few housekeeping notes to go through. Next slide.
Oh, well, it does not want to advance. Hold on a minute, sorry.
That's okay.
It doesn't. Huh.
There we go.
Oh, there we go.
Oh, now go back one. So just a couple of announcements quickly. This year's annual conference will take place in person, October 25th through 28th at the Drury Hotel Plaza Riverwalk in San Antonio. The preliminary conference information, the program is all on the website. We're making a couple of little minor tweaks to the program, and it should be posted in the next week or so. If you change your contact info, please let me know. The annual dues notices have been mailed out. If you did not receive them, please contact the office. And our mailing address and phone number have changed. They're located on the website if you need to have that information. Next slide. So everybody will be on mute except the presenter. Please post your questions in the chat box or in the Q&A box. Today's webinar is being recorded and we will share it shortly afterwards. At the conclusion of today's webinar, we're sending out a brief survey about today's presentation. So just take a few minutes. It's just 3 questions. So I would like to thank personally Beth Connolly, who is actually on vacation, but she agreed to do this webinar for us. And we're delighted to have everybody join us today. She directs the Pew Charitable Trust Substance Abuse Prevention and Treatment Initiative and is the lead researcher and technical assistant efforts across the federal government and states to promote evidence-based transformation of the treatment system, expands the substance abuse disorder workforce, optimize coverage and reimbursement for effective treatments. Before joining Pew, Connolly served as the commissioner of New Jersey's Department of Human Services. She holds a bachelor's degree in social work and a master's degree in public administration from Seton Hall University, and actually is an instructor at Georgetown University. So welcome, Beth. And again, if you have questions, just pose them in the chat box or the Q&A box. And as we go along, if we are stopping at a slide, we can go through the questions. We would also like to thank all of our sponsors who made today's presentation and all of the webinars that we do on behalf of our members for making it possible. So thank you again, everyone, for joining us.
And thank you, Kathy. I'm really excited to speak with all of you. I know folks at Pew have been in your circles before, and so I hope I do them proud. As Kathy mentioned, I'm not in my house. I'm in a rental house. So if people walk by or the dog decides that she's very interested in what we're doing, I apologize in advance, but I feel like for the past 18 months or so, we've all been going through this. So please, you know, we can all just smile and laugh at it, but hopefully we'll have some peace for the next little bit under an hour. So again, my name is Beth Connolly, and I direct the Substance Use Prevention and Treatment Initiative at the Pew Charitable Trust. And for folks who are not familiar with Pew, we're an independent nonprofit, we're nonpartisan research and public policy organization. The work that we do, we are not a grant-making organization. Some folks think that Pew is a grant-making organization. We're not. And the work that we provide to states and others, the federal government or other folks, we do free of charge. We use the funds of the Pew Charitable Trust in order to accomplish our work. Through our work, we do research, we create partnerships and we provide technical assistance to states. And this happens across all our programs at Pew. Pew is, people like to say that we look at everything from pensions to penguins. We have a large environmental portfolio. So we're in a number of states and internationally through our environmental portfolio. And then we have a number of government performance groups that work in a variety of places in state government, from looking at state budgets, to criminal justice reform, to health information technology. So my office is one office of many across Pew. So we call ourselves SUPTI, Substance Use Prevention and Treatment Initiative, and we provide technical assistance to states and other jurisdictions. And the focus of our work is to increase access to medications for addiction treatment and to increase services and support. And, looking at the opioid overdose crisis, our focus has been on medications for opioid use disorder. As we all know, that there are only FDA-approved medications for opioid use disorder and for alcohol use disorder. But for all other substances, such as methamphetamines, cocaine, there are no FDA-approved medications yet, which is unfortunate because we know that medications are highly effective. So our focus has been at the state level to work with states and jurisdictions in increasing access to medications for the treatment of opioid use disorder and the support services around them. And we provide this technical assistance through a policy analysis. So we look at states' policies and try to help them figure out where their policies could be improved in order to increase access to treatment. So, for example, there are some states that layer additional requirements on top of, for example, opioid treatment programs, which is the only place where one can be a methadone patient. And so we work with states to unwind these types of policies that can be detrimental to patients trying to access treatment. We also try to help states look at increasing access through barriers that may need some other types of intervention. So, for example, if a state is very rural and they're looking to try to bridge the gap in rural areas, we may recommend medication units, which are satellite OTPs. Perhaps before last week, we were working with states on mobile vans for buprenorphine, but now with the recent DEA regulations that were promulgated, we can now talk about mobile methadone vans across different states. And coming from New Jersey, we were fortunate enough that we did have mobile medication vans, and they've been a huge support. So we've looked at things like that, and then trying to work with states on workforce issues and other support issues, harm reduction also, to really support people with opioid use disorder. At the federal level, we will advocate and lobby on particular bills in Congress that are related to increasing access to treatment. Currently, we are lobbying on the MAT Act, the Mainstreaming Addiction Treatment Act, which seeks to eliminate the waiver required to prescribe buprenorphine. We do a lot of education of federal legislators and also the executive branch. So the research that we do, the research that we find, we bring to federal legislators and to the executive branch agencies in order to help provide them some additional information. We recently, which I'll talk about in a little bit, had George Washington University do an analysis for us of some of the regulatory relaxations offered during COVID. And so we've been spending a great deal of time educating the executive branch on the findings of the George Washington report. So Today we're going to talk about buprenorphine, and I'll preface this by saying one of my great teammates, Jenna Bluestein, will be speaking at your conference in October. And so I'm trying to be cognizant of her specialty, which is really low barrier buprenorphine, and sort of give you the backstory so that when you go to the conference, you won't, number one, hear lots of regurgitation of the same thing. But also you'll have sort of the backstory of what led us to her work and why we think this is so important. So today we will talk about buprenorphine from sort of a higher level than the actual on the ground and in the community distribution. So buprenorphine, I'm sure many of you know, given what you do, is the only agonist medication that can be prescribed in an office-based setting. There's a long history for folks who are not familiar. Buprenorphine was once only available at OTPs, and in order to bring buprenorphine into an office-based setting and thereby bring it to more people, hopefully, and easier access, because if you're at a trusted PCP or in another office-based setting where you feel comfortable, you might be, ready to ask for help with your substance use disorder. So in 2000, there was the Data 2000 Act, which actually created the Buprenorphine Waiver. The waiver is required for folks to actually prescribe buprenorphine. We know that buprenorphine is highly effective. We know that it reduces the death rates due to opioid overdose. We know that it's helpful in staving off and reducing the contraction of HIV, hepatitis C. We know it's a safe medication. It has a ceiling effect, yet it's highly regulated. So you need to have a waiver. When you obtain the waiver, you are required to have audits by the DEA. And so there are a number, you're also required to do hours of training depending on what level practitioner you are. And so we see that there are few prescribers across. The latest data I believe I saw was about 6% of physicians with able to prescribe controlled substances were actually waivered to prescribe buprenorphine. And that may be a little old because it is beginning to change with some recent federal changes. So in the Support Act, so before the Support Act, there were physicians prescribed buprenorphine. And then in the Support Act of 2018, buprenorphine, there was the cap on buprenorphine. The cap was at 100 patients. So you could, as a prescriber or physician, you could prescribe for up to 100 patients. 30 is the minimum, the entry level, if you will. But it increased the cap, so prescribers could prescribe up to 275 for 275 patients. It also expanded the pool of people who were eligible to prescribe, so nurse practitioners, physician assistants, and all of these other specialties through the Support Act were given the ability to prescribe. However, this ability to prescribe actually runs out in 2023. So there's a time-limited space where these new practitioners could prescribe buprenorphine. And, when these types of arbitrary dates are put in legislation, this one, for example, another piece was put in for Medicaid coverage of medications for opioid use disorder. Medicaid and Medicare are required to cover them in every state unless the state has filed for an exemption. And that for Medicaid side, that has an end date also of 2023. So, the fear in the community is that with these end dates, if something isn't done to either extend them or eliminate the waiver, or on the Medicaid side to make it permanent that Medicaid will cover medications for opioid use disorder, we will create a cliff and we will have people who will no longer be able to obtain services. So this is definitely something that the advocacy community is worried about and working on. So with the Support Act, we've seen the greatest increase has been seen in the mid-level practitioners, so your nurse practitioners, your physician's assistants, but not necessarily in the CAP participation, meaning physicians who are previously prescribing are not prescribing anymore, but there's been an increase in the number of prescribers in terms of the mid-level practitioners. And so that has been something great for the field, especially if you're looking at underserved areas, such as rural areas, where, that there's very few waivered prescribers in rural areas, which creates a huge barrier and an inequity to folks in rural areas, that these mid-level prescribers have really become part of the treatment system and a critical part of the treatment system. We examined some claims data through our research, and this was health claims data around buprenorphine for waivered prescribers. It's available in JAMA Open Network, and I'm happy to send Kathy the link if anyone is interested. But the examination of claims data found that about half of the waivered prescribers were actually doing the prescribing, but most of them were treating patients at levels below the prescribing authority. So likely they were just working with folks who are already in their practices and were not providing any bringing in any additional folks. It's really a small number of folks that then prescribing, if you knock down the small number of folks that are waivered, and then within that, the small number of folks that are actually prescribing. And so let me go back. Well, I can do so. One of the things we find is through our research that folks are hesitant to become prescribers for a number of reasons, and among them, the education requirement, the DEA oversight, and we still find that there is a great deal of stigma in the provider community. I wanted to take this little sidestep because I know that your work with Pew in the past has centered around prescription drug monitoring programs. And so part of our work in looking at how to create access to evidence-based treatment, we've been looking at claims data, but the PDMPs, they're really a great resource for states to help track treatment. And so states can look at, who's prescribing, where are they prescribing, and, you can really dig down into this PDMP data and look at where there might be gaps and where, especially if who's able to prescribe, which is publicly available. The DEA makes this information publicly available, so anybody can know who is waivered in their community. And then states can take that data, overlay it into with their PDMP data and see are people are there waivered prescribers in their communities if they're not seeing what they would think would be a reasonable or amount of buprenorphine prescriptions. And if there are waivered prescribers, then they're not prescribing if they're not seeing them on the PDMP, but also they can also learn from the DEA data if there's no waivered prescribers in their area, and then work to increase access that way.
Beth, I do know in the chat box, I know there was definitely interest. If you could send me that study and I can send it along to everybody. And excuse the dog barking.
No worries. All right, I'll send that over to Kathy. So the prescriber hesitancy is something that we've seen in the very small number of people that are actually waivered. So the waiver requirements are education related. So there's 8 hours for physicians, and for mid-level prescribers of 24 hours. We hear from folks who have taken the training, and I am not a physician nor a prescriber, but what we hear from docs who have taken the training and mid-level professionals who have taken the training is there's very little. There's lots of training you can take. There's there's different types, but much of it focuses on the actual obtaining of the waiver, and very little of it pertains to treatment of patients, and so folks have found the waiver training to be somewhat inadequate, but nonetheless it's time that's taken away from their patients. In addition, the waiver does require that there is DEA can come in and audit. We heard from some of the providers that we've interviewed that the DEA audits can be very stressful. And this is, another thing that sort of leads either a prescriber, but also if you're looking at more of an institutional setting, like a hospital, we've heard from emergency room doctors that sometimes the C-suite is not interested in docs who are waivered prescribing in their emergency departments because they do not want, again, that DEA oversight that comes with the waiver, and they do not want that descending on the hospital. So these are some of the waiver requirements that we've seen and been told that are creating a hesitancy among doctors. Another is lack of education. And, only recently have states and medical schools started to provide levels of education around addiction, substance use disorder. And so a lot of doctors have, long been out of med school. And while all but, and I think it's all but 8 right now. I could be wrong. It changes, these kinds of things can change frequently. 8 states require continuing medical education, or CMEs, in addiction medicine or in substance use disorder. So states are finding ways to bring this education to the workforce, but some doctors feel that they have a lack of education, and so that creates a degree of hesitancy. Then a lack of office support, and that can range in a number of different ways. Finding ways to connect people to counseling, finding ways to help folks with other needs that may result. So sort of these wraparound pieces that some doctors feel that if they had someone else in their office that could be lending a hand there for that, that would create, a much better environment for them to provide this treatment. And finally, I mentioned earlier, there's stigma. There's stigma of the medication, stigma of the people who use drugs, and this is pervasive in not only, our general society, but within the medical community as well. We see many reports of stigma. From my own work, I can tell you when we were bringing peers into emergency departments in our hospitals in New Jersey, we were met with a great deal of resistance from doctors who were in emergency departments because they did not see the value of a person who, and I'm going to use air quotes, but was a drug addict or a former drug addict. And what value did they bring into the emergency department? And they were not trusted. And there was lots of stigmatization around people who came in having overdosed. And I see them all the time, and so why are we bothering to give them extra support? And it was awful. It really was. And I can tell you that once we found some amenable emergency departments who welcomed peers, the word spread across the community, that the peers were supportive, then docs were not seeing patients over and over again, and that the value of peers and the perspective of the person who used drugs, and the idea that that this is a chronic disease to be treated like all other chronic diseases, but it took this real push on our part to sort of break down a lot of that stigma. I remember talking to one doctor, several months later after this, and they said to me, I worry, I wonder, like, what happens when they leave? Like they felt, all of a sudden, they felt such a connection because they made this connection with the peers and the other support the peers could give. And when the patients would leave the ED, this particular doctor was like, I wonder where they go. I wonder how they are. And so this was, that was like, oh, wow. For me, it was, quite a turn of events, and, nothing could have made me happier actually, but it took folks, to witness and see. And then once they witnessed, it took their experience to convince their own peers in the medical community that this was the right way to go. We still have a long way to go with stigma, not going away, but it's part of me thinks that one of the, and I hate to use it, but I say it every now and then, that one of the silver linings of COVID, which there really are none, but is that people are starting to see folks in their own communities, in their own households. And it's with substance use disorder, with, struggling with mental health issues because of the pandemic. And all of a sudden, it's starting to hit home. And this is sometimes what helps to reduce the stigma. But certainly we have a very long way to go. So recently, the federal government has offered pandemic regulatory relaxations. These relaxations fall into two categories, one around methadone. So methadone is only available at an opioid treatment program. This is even, methadone is even more restrictive, of course, than buprenorphine. And there's guidelines and regulations around medications. So typically you go to an OTP every single day to receive your medication, receive your counseling. Of course, during the pandemic, this was not advisable. And so there were regulatory relaxations allowing stable patients to take medications home with them for up to 28 days. And then receive the counseling portion of their treatment via telehealth. So the other side of the regulatory relaxation revolves around telehealth. And specifically for buprenorphine, buprenorphine could not be prescribed previously without an in-person analysis and evaluation, and of course, not recommended during COVID, and especially in the early days, way before vaccinations. And so now, under the regulatory relaxations, people can receive buprenorphine and be prescribed buprenorphine with a telehealth visit, with a discussion and an assessment over a number of platforms. Through these regulations, the HIPAA required, the HIPAA supported platforms that were required to be reimbursed for a telehealth visit, those were relaxed. And so folks were able to prescribe and to conduct telehealth visits, conduct counseling over the telephone if you did not have a smartphone, over the iPhone and the chatting and all of these different mechanisms, FaceTime, that were not HIPAA compliant practices before, were all of a sudden now available to people. And we have been seeing, and there's been a number of researchers in different states who've been looking at this, the uptake in medications and in counseling has been significant over the course of time. So these regulatory relaxations really have impacted the field and the delivery of services to this community. You may remember, go ahead.
Oops, sorry, Beth. I don't know if this is the right time. I apologize for interrupting.
Okay.
So there is a question. Can you comment on a 2019 New Jersey pilot program that allowed paramedics to carry and initiate buprenorphine treatment to overdose victims in the field?
Yes, I can. Actually, I don't really have much comment. I retired from the state government in 2018. So this pilot came about, it's at Cooper Medical Center. But my colleagues at Johns Hopkins University are the evaluators. And I have been bugging them with great regularity about what they've found so far. And it hasn't got, as far as I understand, and again, I'm distant from it. So my last interactions and discussions with the researchers at Johns Hopkins were that it hadn't really gotten off the ground as robustly as they had hoped, meaning Cooper. I'm not quite sure where what were the drawbacks, but I can tell you that the governor signed into law as part of, when they have, when the budget season hits, all the bills, every state government knows that there's a stack of bills that go to the governor's desk, and that actually prescribing and initiating buprenorphine via EMT was one of the bills that landed on the governor's desk that, as far as I know, he signed. So there wasn't any evaluation, which, the research side of me says, oh, goodness, we could have made the bill better. But the public policy person in me says, well, this is an emerging best practice, and, it's another tool in the toolbox for folks who might need treatment. So I think hopefully Johns Hopkins will be publishing soon-ish. I'm not quite sure. I keep asking them, and they're still doing the data collection because of the small, right now, the smallness of the pilot. So keep your eyes open, and you can certainly look at look for the bill online. I haven't read it, I have to say.
Thank you.
Are there any other questions, Kathy?
Not at this point, no.
Okay. So you might have remembered at the end of 2020, there was some prescribing guidelines or guidance that were issued very rapidly around prescribing of buprenorphine. And essentially, the 2020 guidance, I think, came out in November or December, said that, you didn't need a waiver to prescribe, and, go forth and prescribe. And that's really a sort of making it much more simplistic than it actually was. But when the new administration came in January, they pulled back the guidance. The guidance was flawed in a way because it cut out the DEA portion without truly cutting it out. In other words, it said, docs, you can prescribe, and you don't need a waiver. But it didn't speak to the DEA requirements. And so any doc that would have prescribed under the old guidance would have been in violation of all the DEA requirements, because the guidance was only offered on the HHS side. It wasn't coordinated with the DEA side. So it really put doctors in a space that, should the DEA decide to go out and this was, an offense that, an arrestable offense. So, should they have decided that that's the route that the DEA wanted to take, this really put a lot of doctors in jeopardy. So the guidance was withdrawn and new guidance was issued. And I believe it was issued in about April. And what it requires is it does not require the education, and it requires a notification, so pretty much a letter to DEA saying, I am going to prescribe buprenorphine. And there is a cap for folks who go this route, that they may only prescribe up to 30 patients. And if you want to prescribe for more than 30 patients, you will be required to then go through the full waiver process. DEA's issues with the prescribing of buprenorphine revolve a lot around diversion. And, DEA is quick to often say that buprenorphine is the most diverted medication. I am not seen the data personally to sort of go and, really investigate where the data are, where they come from. Nobody on my team has either. But the anecdotal outcomes right now are that there has been an increase in prescribers at the 30 level, which is very exciting. And through regulatory relaxation, there are some, it's unpublished yet, but it's coming, So there'll be a study out of Yale that really looks at the regulatory relaxations and has a specific bent looking at diversion. Is diversion happening? And so keep your eyes open for that. There's been some studies out of North Carolina and a couple other states that have looked at the take-up rate of medications for opioid use disorder and of the counseling via telehealth, and they've found that there has been a significant increase. They've also found that there's been an increase in adherence to medication, which is a huge win. And we're hearing from states that they are actually seeing very little diversion. So we're very anxious and excited for this report out of Yale. It's funded by the FORE Foundation. And so we're really anxious to see this because what we hear is this very, the drumbeat is diversion. There's so much diversion. We know from our research that people divert their medication, their buprenorphine, to help others who are sick and who are going through withdrawal. But that's, we're really looking for the data out of Yale for that, to confirm that. So we commissioned George Washington University to go through the regulations, these relaxations, and tell us, do these regulations, we wanted, we thought that this would be a great thing for them to be made permanent. Really the take-home medications and especially the prescribing of buprenorphine via telehealth without an in-person visit. And so they went through all of the regulatory relaxations, and I will also send these, the link to these reports to Kathy. And so what they found through the relaxations is that the authority to make these regulatory relaxations permanent, because right now they sit under the public health emergency. Once the public health emergency is over, these regulations, these relaxations go away. And so there's a lot of authority the president and HHS secretary have under a public health emergency. So we wanted to know, did it require an act of Congress to really make these things permanent absent the public health emergency? And so it turns out that the authority for permanency for these lies solely within the administration. It does not require an act, none of them require an act of Congress. They can be fully made permanent through the executive branch. They require the avenues by which to make them permanent. In some cases, require regulatory changes on the part of SAMHSA, regulatory changes on the part of DEA, or revised guidance on the part of both. There's a few ways that agencies can go move ahead in making these regulations permanent. They could author new regulations. They can, do joint rulemaking between DEA and SAMHSA, or currently there stands an opioid use disorder public health emergency, and so they could continue under that public health emergency. But again, if the opioid use disorder, the opioid public health emergency ends, then they revert back to the prior regulations. So that really is not the preferential way. We have done a number of follow-ups with the administration discussing these regulations and the avenues, and we will talk to anybody who will talk to us. And so we are hopeful that armed with this legal analysis, that they will be able to move forward. So that's TBD on that. So again, I mentioned this before, well, one of the pieces. So, you know, if we go back to the PDMP, last year there was a researcher from RAND who worked with the Texas Board of Pharmacy to track changes on buprenorphine prescriptions during the early months of the pandemic. And so this is, you know, Texas PDMP data. And one finding was that buprenorphine prescriptions for new patients tripled during the first 3 months of the pandemic. And I can send this as well. But this is a huge outcome as a result of these regulatory relaxations, that patients are finding their way and feeling comfortable. We know that when you create an easy access for patients, such as, you know, they're not having to worry about childcare, they can, you know, they don't have to worry about trying to take time off from work. All of these things make access so much easier, so that when someone is ready to receive treatment, that treatment is ready for them. You know, when folks are ready, if treatment is immediately available and people can be engaged in treatment, the outcomes are, you know, very successful. So we have been working on waiver elimination. And so the waiver itself to prescribe buprenorphine, really the authority lies with enforcement at DEA. SAMHSA has a requirement for guidance and regulation, but Congress is the only one who can reverse the Data 2000 Act and eliminate the waiver. So there are a huge coalition of agencies like Pew and other more focused advocacy agencies, also agencies dedicated to homelessness and more broad public health, and the AMA, who are advocating and really lobbying Congress to please, you know, reverse this. And so the means is a piece of legislation. It's bipartisan and bicameral, so it has support of Republican and Democratic support in both the House and the Senate, and it is working its way through. It was very close to passing at Christmas time, and it was pulled from the bill at the last minute because some members of Congress were skeptical that there was proof that this bill, it was a package for COVID relief, the American Rescue Plan, and they were skeptical that this really was meant to address the pandemic. We all know now, since you know, last month, even that we have the highest overdose death rates ever, and that are related to substance use and primarily related to opioids. So hard for folks to understand how one doesn't see that decreasing barriers to treatment doesn't support people who have been negatively impacted during the pandemic.
Beth, I did want to mention to everybody on the call and to you as well. I'm hoping that you'll be delighted, but one of the resolutions that we have that's being proposed for our business meeting this year is a resolution that addresses the issue of removing barriers to treatment, including any and all efforts supporting state and federal measures to reduce barriers to effective treatment for substance abuse disorders, blah, blah, blah. I'll send you a copy of it. It hasn't been voted on yet, but certainly if it goes through in any of your advocacy work with others, you know, you can certainly use that or loop us in some way. Oh,
well, thank you. That's really exciting news. we have been working with a number of agencies, and as the boat gets bigger and bigger, I have to tell you, it's harder and harder for members of Congress to ignore. You know, the death rate is very stark and alarming, and you know, when you think about crisis situations, we know research tells us, and I can report from, you know, all the crises that we've had in New Jersey when I was, you know, I was with the department for 30 years. And so, you know, the number of hurricanes and other places where we would deploy some of our mental health staff to other states, I can tell you that in every case when you see a crisis, you know, Superstorm Sandy, Irene, or even Joplin, Missouri, the Deepwater Horizon, people's need for substance use services and mental health services increases. But unlike all those crises, which may be long and extended, they're rather time limited. And they're also tend to be really in a concentrated community. And so, you know, supporting these communities really happens from, you know, many angles. In New Jersey, Superstorm Sandy, you know, we had support from states that really came into New Jersey, and we had people supporting folks in so many ways. But when you look at a pandemic and you look at the width and the breadth of what's happening, the need for these services is not going to go away anytime soon. It is going to be with us for a long time. And to watch the death rate climb the way it has should be alarming to our elected officials, and especially those who are not supportive of finding ways to increase access to treatment. So the appetite on Capitol Hill is mixed. There are a good number of sponsors, and the fact that it's bipartisan, but there are a number of holdouts. There are a number of holdouts among physicians, which is alarming to me and to many others. So with that, I will end and happy to take any questions that may have come up. There's not too many in the chat, but maybe you know, comments, questions. Happy to field any of those.
So again, you can type your questions or comments. I do see something in the chat box that said state departments of insurance can require health insurance companies to provide information detailing the number of waivered practitioners actually seeing patients for opioid disorder care and networks. So again, if anybody has any questions.
There have been another, you know, states who have used the prior authorization, you know, as a mechanism by which to help deter, you know, authorizations that will negatively impact the prescribing of buprenorphine, but not all states. So this is another mechanism by which, at the state level, states can actually be helpful in reducing some of the barriers.
There was another comment, excellent presentation. The May report makes a strong case for low threshold buprenorphine treatment and how state policies should be changed to facilitate this model in light of the ongoing opioid crisis. What is low threshold treatment? From the report, it appears to be accelerated access to medication and delinking required counseling services from reimbursement bundles. Low threshold is often categorized as harm reduction, similar to syringe exchange, etc., to further disparage MAT. And then there's another question at the end. I don't know if you can read the Q&A box. Okay, perfect.
Yes. So I can address the low threshold buprenorphine, and I hope you'll actually go to the conference and attend Jenna's presentation, because she pretty great. But one of the issues with buprenorphine and often is the requirement for counseling. And so where you can ensure that people have access immediately, that's really important. Not linking it to counseling, also important. And also recognizing that this is a chronic disease and people may still use drugs. And so not ejecting people from services if they're still using drugs is critical, because we know that with their chronic disease that people are likely to relapse. But you know, if you think about also the EMTs, that is also an example of low threshold treatment, because getting people to at that moment and having it ready for them without requiring anything else of them is critical. So that also can help cross over. And then I see that there's a question about the need for jails and prisons, and yes. So folks who are especially re-entering, once they have completed their sentences or are being released on parole and probation from carceral settings, are at a very high risk of overdosing, because folks have either, and the idea that, and I worked very closely with the Commissioner of Corrections when I was in New Jersey. We opened up a prison that had full drug treatment, all 3 forms of medication and counseling. And he would often say, if somebody says they have no drugs or anything behind bars, that they're lying to you. So he knows, but it may not be, you know, what folks have access to, or when they leave, they go back to using the same amount of heroin or drugs that they had been using prior to their incarceration, and they have a reduced resistance and they're likely to overdose. Additionally, there's so much fentanyl in the drug system that that folks who are being released are very at risk of overdosing. So having access to medications when folks are within the correctional setting is critical. We have some anecdotal information and some small studies that also report that having access to medications reduces incidences across the jails and prisons. We've heard this from, and while they haven't done an evaluation, we've heard this from a number of wardens in the places that we have worked. And so they report that it's a really positive impact for folks. And then connecting folks with medications as they exit, especially if they have been receiving medications behind bars, but also important if there's known to be a prior opioid use history or substance use history, is having that seamless connection when people walk out the door. Part of this is in states where Medicaid has been expanded, making sure that Medicaid is available immediately upon release. So in some states, Medicaid is terminated when someone enters the jail or prison setting because Medicaid dollars, federal dollars, cannot be used to pay for care behind bars. And so some states, rather than terminate, they suspend Medicaid. And so that allows patients who are exiting the jails and prisons to have more immediate access to their Medicaid and then immediate access to treatment. But connecting folks with treatment is really critical. In Baltimore, they have a mobile van, and so as people are released, they are connected with treatment. So right there. In Pennsylvania, the Philadelphia prison actually does, they have 3 forms of medication behind bars, and they also have a robust program in connecting people with medications. And in fact, we've heard from their medical director that they will take people who are being released to treatment centers, to an OTP, to outpatient treatment upon release to ensure that they have this connection. But this is a very vulnerable population. There are some issues around bail reform. New Jersey is a fully bail reform state, and many states are following suit. And it means that folks are coming in and out of the jail systems much more quickly. So it's important that folks are assessed and that there are mechanisms by which to connect people who won't be incarcerated while they await their trial, but they can be connected to services.
So Beth, I just want to thank you on behalf of NASCA. You obviously are incredibly passionate and knowledgeable, and I know I certainly learned a great deal. If you would follow up with some of those studies, because it's not something I think a lot of us have seen, I can certainly make it available to any of our members. So again, thank you so much. Thank you for being, oh my God, my cat's hungry now. And thank you, sorry, the life in Zoom. We really appreciate all of your efforts as far as, being available today and at the in-person meeting as well. Terrific presentation. So again, thank you.
Thank you all. I really appreciate it. And Kathy's right, this is a passion. And so I am happy to have an audience at any time.
Thank you again.